Along that line, and Andrew, the drug was approved by the FDA literally 5 days ago on Monday. We are Friday, it was on Monday. So tell me a little bit, are you using it or what's your experience?
So I have to be very honest. I think for cabozantinib, the experience that I have was still relatively anecdotal. I definitely have used that in patients, who are actually going through clinical trials. I have definitely using it right now with selected patients. I agree. I think it's another TKI. I think you definitely need to, to be vigilant about, all the TKI-related side effects, including hypertension. We need to make sure that, the GI side effects are also, managed well. The fatigue is probably also something that we need to be vigilant. And also, nobody actually mentioned about the dosing. I think, we have to really get a better sense, what's the optimal dosing for cabozantinib in our patient population. In my opinion, that, if we actually follow these patients, they actually develop, dose-related toxicity. I think, lowering the dose to 40 milligram, and these patients will tolerate better and also get longer drug exposure. This may actually really secure them to get the benefit of cabozantinib. So I think there's a learning curve. I'm pretty sure, with the approval of the drug, I think the next few months to the next 2 years, I think we're going to actually have enriched experience in the clinical setting.
No, I totally agree. If anything, the drug is relatively well tolerated. Definitely fatigue might come into play, and no doubt the dose that was chosen for the trial was the appropriate one that understandably people definitely tolerate rather acceptably well. And it's fascinating. This is it's amazing that we're sitting here today, literally exactly 1 year ago, at GI ASCO 2018, we presented the data of the phase 3 trial, the Celestial study. And then in July 2018, we had the New England Journal of Medicine report on the cabozantinib. And here we are today, literally exactly 1 year with an FDA approval for the drug. That's really what I would say, a great move. And more importantly, it's a great, other choice of therapy for our patients. That's really what we are definitely very thrilled about. With this said, the story did not really stop. Actually, it keeps going. And if anything, we have another drug that come into play. And maybe, Katie, you can tell us about ramucirumab and what is it? What do we know about it until the REACH2, which, of course, we'll let Andy talk about as well.
Sure. So ramucirumab is a VEGF-R2 monoclonal antibody humanized that's approved in other tumor types, including colorectal, and so and gastric, and so we have familiarity with it in GI cancers, and prompting a study called REACH, we refer to it retrospectively as REACH1, but the first REACH trial looking at ramucirumab versus placebo in the second-line population was conducted and published a few years back with Andrew's leadership. But quite interestingly, in subgroup analyses, there was a trend that was observed showing benefit predominantly in high alpha-fetoprotein subgroups, really across a range of elevated alpha-fetoprotein tumor markers. And that observation led to, I think it's not fully understood, and I'm eager to hear what Andrew says, but I think one of the suppositions, either it's a poorer prognosis group with greater effect size, or potentially a biomarker of susceptibility to anti-angiogenic targeting owing to the underlying pathways activated in the alpha-fetoprotein signaling in that profile of cancers. But the genesis of REACH2 is that this subgroup analysis of REACH1 showed benefit in the high alpha-fetoprotein biomarker selected subgroup.
So maybe it will be the right thing to do, Andrew, is to ask you, because you led the REACH2. So tell us about the REACH2, and also, as we understood from ESMO, there was a evaluation of collection of the data together, the pooling of the two studies together. Tell us a little bit about that.
Yeah, so as Katie correctly pointed out, that this is a drug specifically targeting VEGF-R2. I think angiogenesis has been implicated as a very important pathway for HCC. But having said that, all the TKIs that we mentioned, they're not specifically targeting VEGF-R2. Sure. So you always have to say, wow, is this really driven by VEGF-R2? We all believe that. But I think, with a drug that's actually specifically targeting VEGF-R2 that shows clinical benefit, we're really validating the pathway of angiogenesis is critical for hepatocarcinogenesis. And secondly, in the initial REACH study, we definitely observe a trend in the intent to treat population, as Katie pointed out. But on the other hand, it did not meet the statistical significance in the whole trial population. But those with high AFP, they actually have very poor prognosis, and they definitely actually fare very, very poorly. But also, when they actually received the ramucirumab in that study, the magnitude of improvement was actually very, very reasonable and with a hazard ratio of 0.69. So with that initial finding, we actually pursued the REACH2 study looking at this specific population. And I think, in the competitive landscape that we're facing for drug development, we obviously, took a very practical approach. So instead of running a 700-patient trial, we decided actually to see whether we can actually pick up the minimum number of patients to actually reproduce the benefit. I think you can argue for that reason. I think, in the end, the study was positive, but perhaps not as positive as we would like in terms of the absolute magnitude of the difference in survival. However, keep in mind, hazard ratio was 0.71, which is incredibly comparable to all the positive trials we all mentioned today, including RAGO, CABO. So the hazard ratio was incredibly comparable. I think this is another good option for the patients, with this disease. And obviously, the challenge for all of us sitting here is really, how to position each drug, and also, how to really partner the existing drugs with additional agents.
So, Rich, I would love to hear your thoughts. Is AFP a tumor marker?
Well, yes, it is a tumor marker. That can't be argued, right? I think the question is it a prognostic marker, right? It is a tumor marker because it's increased, as Andy said earlier, in about 2/3 of liver cancer. Normally, it's very low. And the question is, what does it mean when it's elevated? I think we've seen in several studies that a high AFP tumor doesn't behave as good as, or the natural history of that tumor is not the same as one that has a normal or low AFP. Some of the molecular studies that have been done suggest maybe AFP represents a more progenitor type of liver cancer, maybe one that's not as well differentiated, and biologically it's a marker of something else that's driving the tumor. I think that's the prognostic component. The question is it a predictive marker? And I think that's been determined, and the answer is yes. You alluded to the Tivantinib study that looked at c-Met IHC, immunohistochemistry, that did not pan out, and that might have been the failure of the assay or the failure of the drug. But now we have a prospective study, two prospective studies, one taking all comers with a drug that is negative, and then one that is prospective selecting on this biomarker of high AFP, and it's positive. So I think we can now say that a high AFP is prognostic, it's a poor marker of a bad outcome, and it's predictive of response to ramucirumab.